Hi everyone, welcome. My name is Corinne and I will be your moderator this evening. I'm excited to welcome Dr. Mahjoubi as our speaker tonight, as she's going to go over when extractions are extra challenging, how, why, and what to do. Before we get started, I would like to take a moment to go over some housekeeping. If you have a question, please type it in the box labeled "Have a Question," and Dr. Mahjoubi will be on answering those individually. CE is not available for watching this webinar live or on demand. Dr. Mahjoubi, welcome. I will pass on over to you now. Thank you so much for being with us.
Good evening, everyone. I'm Dr. Ghazal Mahjoubi. I'm a board-certified or maxillofacial surgeon practicing in New York City. I've been in practice since 2012. I practice a full scope of oral surgery in my practice. I also teach at a hospital that has oral surgery residency program twice a month. Today, we're going to talk about a common topic, which is dental extractions and complications and benefits of cone beam CT. I'm going to show you guys a lot of clinical videos and pictures to make the lecture more interesting so we can all benefit from it. So as we all know, there are different reasons teeth need to be extracted in our practices. Number one reason being dental caries, when teeth become unrestorable, and unfortunately we have to extract them. The other reason is orthodontic treatment if there is overcrowding. Periodontal disease is another reason patients have to have dental extraction due to bone loss, as we all know. The slide on the right is a slide of actually a picture of my patient tattoo that she got it during pandemic, and those two hands represent that two hands that are close but they can't touch, a period of isolation. The reason I put that on is another reason we remove teeth more after pandemic is fracture, and a lot of patients are under more stress and there is more clenching, and therefore that leads to more fractured teeth and more extraction. So I thought for you guys it was interesting to see that picture of her tattoo. The other reason is if there is pathology associated with the tooth, like a cyst or a tumor associated with teeth get extracted. Another reason is teeth in line of fracture. If there's a mandibular fracture, if there is caries teeth and fractured teeth in line of fracture, we have to remove the teeth before we place titanium plates on to reduce the mandibular fracture. So these are some common reasons patients get extractions. What we want to consider before starting any extraction, just like any other procedure in our office, is to go over medical history of the patient. We want to make sure we go over the list of medications that they take. I cannot stress it enough that we need to go over medical history verbally. A lot of our patients have dealt with a certain medical condition, such as diabetes or high blood pressure all their life. And sometimes they forget that they have a certain condition or they've had a surgery in the past that might affect them. So I think going over these verbally with patients help us not miss important information. A lot of times our older population of patients have been on bisphosphonate in the past, or they've had chemotherapy or radiation, they forget. And when we talk about it, a lot of information is given to us. The other thing is importance of getting a medical consult. I think it's important that when we are requesting a medical consult for us to be very specific. A lot of times medical consults comes very generic, and they write that, oh, no epinephrine, or you need antibiotics, or you don't need it. And sometimes that's not the information that we need. Sometimes we need more. We need more guidance and more information regarding patient. I think if we give our medical colleagues a more detailed request, we might get a better answer from them. So I'm going to focus on a couple of different medications that will affect our extractions. and how to manage those. One of them being anticoagulant therapy, when to interrupt them, why interrupting them is good or not. A lot of our patients take anticoagulants to prevent thromboembolism if they have atrial fibrillation, which is an irregular heartbeat that can lead to a thrombus, and that can lead to stroke. So a lot of times that's why they're getting treated. Sometimes after certain procedures they're on anticoagulants. Sometimes it's for treatment of DVT. In general, dental procedures are considered low risk for bleeding. So we really need to be very careful when we are asking our medical colleagues to stop anticoagulant therapy for small procedures, because a lot of research shows that actually the risk of getting a thromboembolism from stopping a patient's anticoagulant therapy is much more than having a risk of bleeding from a dental procedure. So in my practice, I do not stop anyone's anticoagulant therapy for surgical extractions. If it's a bigger procedure, we usually switch them to heparin bridge, and then we can have less risk of bleeding. But for small procedures, I think local measures can be effective in stopping bleeding, and we don't need to stop their anticoagulant therapy. This is just the blood cascade of clotting that we all know of, intrinsic and extrinsic pathway, and some of the medications that are used. Warfarin is not used so much anymore. It's rare that now I see patients on warfarin. Newer classes of medications such as Paresthesia are used more now that are direct inhibitors. The good thing with warfarin was that we could monitor it with INR, and we usually got the INR the day before, and if it was before 2 and 3, there was less risk of bleeding. But with the newer classes of medication, there's not a real way to monitor. So, but like I said, most of the time for small procedures in the office, we don't stop them, and we just rely on local measures to stop the bleeding. The other class of medication that I want to talk about is medication-related osteonecrosis of the jaw, which is actually a very debilitating problem if it happens. So it can happen in patients that are taking bisphosphonate anti-resorptive therapy in conjugation with immune modulators or anti-angiogenic medications for cancer treatment. Because it changes bone turnover, it can lead to merange of the jaw after a procedure. By definition, merange is exposed bone that can be probed via intraoral or extraoral fistula, and it has to have been in the region for more than 8 weeks. Also, the other thing is there should be no history of radiation therapy to jaw or metastatic disease to the jaw. So for this to be called merange. So these medications are bisphosphonates, Venusam or Prolia or Romosam. They are really good in preventing fractures, but as a side effect, they can lead to development of merange after dental-alveolar surgery. I've seen cases of merange even without any kind of dental-alveolar surgery. It can happen spontaneously, so it's not always from dental-alveolar surgery and trauma. The risk factors are patients that are older than 65, periodontitis, obviously dental-alveolar surgery, teeth extraction, receiving anti-resorptive therapy in conjugation with anti-angiogenic therapy for cancer treatment. Smoking is another risk factor. Malignant disease such as multiple myeloma, breast, prostate, or lung cancer, that goes hand in hand because of the medications that are used for treatment of these type of cancers, chemotherapy, corticosteroid therapy, and usually when these medications are used in conjugation with each other, then the risk goes higher. When we want to treat our patients that have been treated with these type of medications, we really want to get a sense of how long the medication was used, why is it used, is it for a cancer treatment. The use of drug holiday was suggested in 2009 by AOMS, but it's really not a very significant research that how much it improves it. It is a bit controversial. Some suggest that it doesn't improve much. Also, we have to consider that, drug holiday, sometimes it's not an option for our cancer patients because stopping the medication for 3 months might put patients at risk of advanced disease. So we need to get in touch with our medical colleagues and make a decision as a team in these cases. Also, if there is an infection around the teeth, leaving an infected tooth in place by itself can lead to mirage. So we have to really evaluate it case by case and treat patients. The best way is prevention and screening and dental screening before these treatments started so that we can prevent complications. In selecting our cases that you want to treat in your offices, it's very important to evaluate every case, make sure that you have the right imaging for your procedure and extraction. The need of cone beam CT is very important, especially in cases of third molars. In a lot of cases, it is becoming a standard of care to have a cone beam CT before extraction of third molars. I don't do CT scan for all my third molar patients, but there are definitely cases that do need CT scan. And I believe that it gives me more information, and sometimes I can decide whether I want to treat it as an extraction or I want to treat them as cornectomy and to lower their risk of paresthesia. The other thing that it's good to consider when you want to treat these patients in your office is that you want to make sure you have all the right instruments and hemostatic agents. You want to be comfortable with your suturing techniques. It's always better to have everything that you need beforehand, whether, versus if you're in the middle of a procedure and then you realize that you need a certain instrument and you don't have it. So it's good to always have like a surgical kit separate and have everything in it and have your assistants have that ready for you in case you need it. This is our basic surgery kit set up for dental extractions. We always have hemostatic agents, Surgicel, also gel foams. We also have a cautery in case of excessive bleeding. The other thing that you want to really pay attention to is importance of using surgical handpiece for sectioning teeth and also bone removal. Using a dental handpiece can lead to air emphysema. And this is really a complication that can be easily avoided. It should really not happen in our practices if we use the surgical handpiece. If you're using a dental handpiece and you're sectioning a tooth and you all of a sudden get facial swelling because we're introducing air in facial spaces and patient gets all of a sudden facial swelling and severe pain, that's air emphysema, and it needs to be managed. Usually it needs broad spectrum antibiotics to prevent infection because it can get infected. It also sometimes if it goes to facial spaces around neck, it can lead to airway complications. So sometimes patient needs to be admitted to the hospital for observation. So really, it's a complication that we should not have in our offices if we use the surgical handpiece. So it's kind of important to have that in mind. The other one that we're going to talk about is importance of, again, CT scan, as it shows the position of vital structures such as infraocular nerve, mental nerve, maxillary sinus. It does show anatomy of teeth better. It can show pathology that might be easily missed with traditional radiograph. And like I mentioned before, it is becoming standard of care in a lot of high-risk cases. Here, I want to show you a panoramic radiograph of one of my patients that he was referred to me for evaluation of cyst around number 32. He had an infection. This patient is about 60 years old, so he's older than our average population of third molar patients. As you guys see, I want to make you guys pay attention to the area of upper right. In this x-ray, it's nothing really too dramatic going on around number 1, just it's not impacted. I don't appreciate a big pathology from this radiograph. But, in this case, we took a CT to really look at the extent of the lesion around number 32 and position of the nerve. So here I want you guys to pay attention to area of number 1. As you see, a cystic tissue starts around number 1 and it goes in between root of number 2. And as you see, there is a little bit of a consistency to this lesion. It's a bit unusual. In this case, I did get a radiology report on it because it was a bit unusual. And actually, radiologist thinks that this might be a unicystic amyloblastoma. And as we all know, it's a lesion that needs treatment. And I think this is one of those cases that if the patient did not come to me for evaluation of number 32 with cyst, that case, that lesion could have easily been missed. So it's like, CT scan can be really beneficial in certain cases and certain pathologies that would be easily missed with traditional radiograph. So this is a 67-year-old female patient that had pain and infection around number 17. And from panoramic radiograph, it looked close to infraocular nerve. I took a scan. And as I want to show you, there's a coronal view. We see infraocular nerve, and the roots are, as you see, is wrapped around the nerve. So this is actually a case that if patient was not symptomatic, I would not treat it. I would just observe it. But obviously, in this case, patient is infected. She has pain, and I had to treat it. And in this case, I treated the patient with coronectomy, and she did well. Coronectomy, as we all know, has its own set of complications. If roots start to migrate away and it becomes a problem, we have to go back and remove them. If the remaining portion of the teeth that we leave behind gets infected, we have to go back and remove them. But in certain high-risk cases, it's really the only option to lower risk for our patient. So this is another case of a younger patient, but again, it appeared that roots are wrapped around the nerve, and I drew an infraocular nerve for you to see. And as you see, it goes right in between the roots. This patient did not have symptom, and we chose to monitor and make sure that down the line he does not develop a cyst. And we are not going to do a extraction or coronectomy in this case. I do reserve coronectomy for symptomatic patients. I don't do it as a preventative measure. So this, I just wanted to show you a case of a very high position number 1. In this case, I took this scan to make sure there is no pathology involved with this. I wanted to make sure that there is no cyst that had pushed number 1 to that area really high in lateral wall of the sinus, which actually it was not. The tooth is encased in bone, and obviously we're not going to remove it. We're just going to monitor it. It was just an interesting case to show. We want to talk about a little bit, switching gears. Obviously, lingual nerve cannot be seen in CT scan, but we want to talk about the position of it a little bit, as it can be in the level of alveolar crest or higher in 17.6% of cases. In retromolar region, the distance between the lingual alveolar crest to lingual nerve averages about 4.45 millimeter and ranges between 3 to 2.8 millimeter in the third molar area. So if you think about that, it's a very close distance from where lingual nerve runs and when we are elevating our flap to remove third molars. So we have to be really paying attention to this area. The flap should be done on distal and distal buccal release. We should not really put a release on the crest as we can injure lingual nerve. We also should be careful when we are lifting the flap. We should not really stretch lingual flap with periosteal elevator. I sometimes see that it's being done, and we can easily actually injure lingual nerve by stretching and reflecting lingual flap, because it can be run very close to it. So here you see I have my distal buccal release, and I'm elevating the flap, and then we're gonna go ahead and do the trough. I want to go over some signs that you see in your panoramic radiographs that shows that you probably need to do a CT scan to make sure you know the exact position of the nerve in relation to the roots. So in slide A, you see that there is darkening of around the apex of the root. That shows that's a sign that there's a close proximity to the root to inferior alveolar nerve. In slide B, we see interruption of the radio-opaque canal, which basically shows the absence of continuity, and it shows that the root might be going around the nerve, so that's definitely needs a CT scan. In C, again, we see diversion of the inferior alveolar canal, which shows that, again, close proximity. In D, we show that there is actually kind of like absence of the root, and we know that there is close relationship between root and inferior alveolar nerve. Again, in E, there is complete deflection of the canal, and in F, there is narrowing of mandibular canal, which shows that the roots are going around the nerve. Also, if the root, like in slide G, gets very, very narrow, that means that that's a sign that the roots are very close to inferior alveolar nerve. The other thing that we need to pay attention to in horizontally impacted teeth, such as slide H, is that if that cystic lesion is there, usually that cystic lesion has taken away bone on top of inferior alveolar canal, and therefore it is very close to the nerve. And also in these cases, they're even high risk for cornectomy, because when we are removing the crown, we can easily injure the nerve. So we always have to consider these and do a CT scan and be very clear when we're talking about our consent forms with our patients, so that they all have an understanding of the risks when we are doing these procedures. So again, when we want to consider our cases, we want to just know that, like we talked about, we have all the instrument, we have all the right imaging, we have the CT scan if needed, and now we're going to start our surgical extraction. Obviously, we want to design our mucoperiosteal flap. We want to design it in a way that we do minimal bone removal. We want to expose it enough tooth structure. We want to kind of have a plan beforehand. If we think the tooth needs to be sectioned, I think it's best to be starting the case that way, to section it versus starting an extraction. Now there is a fracture. Now we have to kind of start over, elevate a flap, and start sectioning the teeth. I think it's always good to start it the correct way, and we will have a better outcome. Flaps should be raised so it gives us great visibility. It needs to have a broad base, as we all know. In the third molar region, as we talked about it before, we need to be paying attention to position of lingual nerve. We also need to consider that we want to close these flaps in a tension-free manner. So we want to pay attention to the design of the flap when we're elevating it. So as you see, I go to lift this flap for number 16. I do a distal buccal release, and I elevate the papilla distal to number 15 to get visibility for removing this impacted number 16. I just wanted to show you how I raise my flap. This is just a basic design of a flap. As we all know, broad base, distal release. Broad base is for better blood supply, and we want to have good closure. This is a case of a maxillary first molar extraction. As you see, it is in close proximity to sinus. The roots are long, tooth is root canal treated. There's not much of a clinical crown. So this is a case that I would start with sectioning the roots from the beginning. We also want to preserve as much bone as possible, especially in this case. I was bone grafting the case for an dental implant, so we want to make sure that we do atraumatic extraction and preserve as much bone as possible. As you see, I start with 557 burr, sectioning the roots, minimal bone removal. So as you see, I'm separating roots one by one. I remove it. And in this manner, also, there is less risk of roots getting displaced into maxillary sinus or having a problem such as oral antral communication. When we do these extractions with sectioning and kind of careful elevation of the roots, we're going to have less complications. Staying on that topic, if root gets displaced in maxillary sinus, we need to take a CT scan to know the exact position of the displaced root. And then there are different options for removing it. One option is called the Glock approach, which is the same as our lateral sinus lift. We open a window and then get access into the sinus and remove it. Or sometimes the opening that root got displacing can be enlarged and root can be removed that way. And then we also have to do closure of oral antral communication. Also, in cases that we elevate flap, we want to close these with sutures. In this case, I have grafted it with PRF, and there's a membrane. I'm using fibro sutures. Those have better healing when we close our surgical sites. It's a case of impacted number 17. So when you're doing your trough, you should really stay close to the tooth and just remove as much bone as you need, not more. You want to give great access, and then you want to section the teeth to remove it. In this case, I'm going to section it in the middle. I go 2/3 of the way. You don't want to go all the way because, again, you can injure lingual nerve if you go all the way. So you want to go 2/3 of the way and then put your elevator and separate. So as you see, I am sectioning the tooth and elevating it. So now it's going to be easy to remove it in 2 pieces. Just another case that after trough is done, this is a distal angular impaction. I section the crown, remove the distal part of the crown off, and then I can put my elevator, small elevator in the mesial and elevate this tooth out. I'm going to start. So this is a case of a horizontally impacted number 17. After I've made my trough, I'm sectioning the crown. Usually I section crown in 2 sections. So I make 2 cuts, one here, and I remove the slice of the crown first, and then I put my elevator here and remove the crown. In the next slide, I'm going to show you how I'm removing the crown. Okay, so as you guys see, I'm putting elevator in the mesial after that midsection was removed, and remove the crown. So after the crown is removed, I separate the roots, and then either you can remove the roots with your east-west elevator or just like the straight elevator like I'm doing now. You just advance the roots and remove them one by one. Really, in these horizontal impactions, if you remove the crown well, then removing the roots are not difficult. You just have to separate them and make a trough around them and then advance them. So we always want to close these impacted third molars. We'll get much better healing when we have closure, good closure, especially in the distal of 18 and 31. It also decreases our pocket depth, so we want to make sure we suture them well. So I wanted to talk to you guys about a little bit about benefits of leukocyte and platelet-rich fibrin PRF for our extractions. Literature has showed improvement in postoperative pain and edema when we use PRF. I do see benefits of it in my own practice as well. When we use PRF for extraction sockets, patient gets better healing due to tissue regeneration. So after it's been centrifuged, I'm separating the PRF, and then we place it in extraction socket and suture over it. Sometimes I put some Surgicel over top just to make it more stable. So here I'm just packing the PRF in the site of number 32. And this is a great adjunct you guys can add to your practice because it really improves patients' outcome and healing. I think sometimes it's patient acceptance in a lot of these cases is hard. I think if we really explain it and if they understand that they will have better healing, they might opt for doing these procedures. So this is a case of impacted number 1. I have lifted up the flap with this buccal release. You want to have your Minnesota distal to the side, and you want to make sure you protect teeth from getting displaced into buccal fat pad and temporal fossa or maxillary sinus. So really controlled movement, elevating gently on the mesial is important. It is very important to always have a throat pack in all your extraction cases, so to protect the airway. This is a case of impacted 28. A patient was referred for removal by his orthodontist. I'm going to show you how I did this case next. So in lifting these flaps in lingual region here, we have to be careful. We have to be gentle lifting the flaps because if there is a tear, it's going to be causing post-op discomfort. So we want to make sure that we lift these flaps gently so we can close it nicely. So here I am removing bone overlying impacted 28. I want to make a small trough. These cases can be challenging because these teeth are located in between the roots of the other teeth, and we don't want to cause any type of injury to the other root. We have to be really careful elevating, not to elevate too much against the other teeth. So here I'm elevating the tooth. They can be very slippery, as you guys see. But we can gently elevate them out and rotate them out. And then we suture the area, obviously. So this is a case that was referred to me. It's a 13-year-old male patient was referred to me for evaluation of impacted third molars in addition to supernumerary 22 that's located in between the roots. Orthodontist didn't want to wait for this extraction because he was afraid that if it grows, it's going to become more of a complication in future. And I agreed. And after taking CT scan, we decided to remove it. I'm going to show you guys how I did the case next. So as you see, I have elevated the flap. After removing bone, this is how we remove that supernumerary. This can be challenging because it's in between the roots. We don't want to injure any roots, and that shows more importance of having CT scan because I knew exactly where it was, and I knew exactly where to make my trough to open and to get access to this teeth. Next, we want to talk about some complications that can happen from dental extractions. We want to start with talking about oral antral communication. This was a case that was referred to me from another clinic. A patient had extraction and he had persistent infection and drainage to sinus from oral cavity that was not healing. I think they had attempted to close it with buccal sliding flap once, but the fistula recurred, and this is how he presented to me. As you see, there is a fistula present there, and in a lot of these cases, if there is infection, I usually treat them with antibiotic first and then bring them back and treat the OA. In this case, I decided to treat it with buccal fat pad. Okay, so here, as you see, I have raised the flap and I'm going to excise the fistula first. When we're designing these flaps, we have to make sure we have enough tissue that we can close over the oral antral communication. Also, in this area, when I'm lifting the flap and I'm going to use buccal fat pad, I have to pay attention to anatomy. There is a parotid duct is right there. Sensen duct, so we have to make sure we don't injure that. We can palpate and palpate at the base of molar eminence, and then carefully make an incision, open into the capsule of buccal fat pad. Buccal fat pad is about 10 ml volume. We're not going to use that much of it for closing this type of defect. Some have shown that removing too much buccal fat pad can change the contour of the face, but in these cases, we don't use that much. We just use a little bit. I'm going to show you in the next slide. So here is after I just excised the fistula, and you see how large of an opening there is into the sinus. It's important to appreciate that, because a lot of times if we don't flap these, if we don't remove the fistula, we might think that the opening is small and it might heal on its own. But in a lot of these cases, after fistula is excised, it shows the extent of the opening. So as we all know, there is, if the oral intercommunication is less than 2 millimeter, it can close on its own, but anything larger than that usually doesn't heal spontaneously, and it needs surgical intervention. So as I said before, we want to protect our parotid duct. We want to palpate the base of molar eminence. We want to make an incision over the capsule of buccal fat pad, and we want to carefully remove just enough that I can get a tension-free closure and use that over my defect. In this case, I'm also going to use buccal sliding flap. I also use PRF, so it was like a 3-layer closure. And these cases, these patients do fairly well. I mean, there's going to be swelling for a couple of weeks. It needs careful post-op care. They have to avoid exercise, heavy lifting, bending, all the sinus precautions, but they do fairly well. This is what it looks like when I'm done. I do see patients on weekly basis and monitor their healing. He healed pretty well. Buccal fat pad can also be used for other defects such as orange that we talked about it before. It's a very good vascular flap that we have access to, and we can take advantage of it. Next, we want to talk about my patient's favorite, which they're all afraid of, which is dry socket or alveolar osteitis. They all Google this. They never want to have it. So we want to go over the risk factor, as we all know, surgeon experience, trauma of extraction, smoking, birth control pills. All of these can be risk factors for dry socket. It can be very painful post-operative event for our patients. So we want to do all we can to prevent it and minimize it as much as we can. Chlorhexidine mouthwash in studies have showed that it does decrease the rate of alveolar osteitis. An article in Nitzen observed that there was a high plasmin-like fibrinolytic activities from culture of anaerobe bacteria Treponema denticola, which leads to more dry socket. So that's why use of chlorhexidine mouthwash can help in lowering rate of dry socket because it lowers bacteria. So in my own practice, also I use this. Most of my patients get a chlorhexidine mouthwash, and they start using it the day after 24 hours. And I do see very little cases of dry socket. I can never say that we never have dry socket, but it's very, very little that we see. I do believe chlorhexidine is a very good adjunct and can be used in our practices and can help our patients. The other complication that I want to touch upon is paresthesia, which usually happens with third molar extractions, or if you're removing a lower molar with a large cyst, if you're curating the cyst, and you can cause injury to infraocular nerve. It is very important to have a good informed consent. It's very important to go over the consent verbally with our patient, make sure they understand the risks, make sure that, it's always worse when complications happen and patients state that they've never been told about this complication or they have no idea. So we always want to make sure we go over it verbally. Sometimes it's a good idea to write it in our notes if it's a high-risk case. The other thing is we want to make sure that for all high-risk cases, if we need to, we have a cone beam scan and we have all the necessary information and we make the right decision for patient. And, we want to consider referring high-risk cases if you do not want to treat them in your practice. The other important thing with paresthesia cases is recognizing injury early on and referring to specialists, especially in lingual nerve injury. They need to be referred out quickly. We should not wait months and months on these. At 8-week mark injury of lingual nerve, if there is no improvement, I would consider referring them to a specialist for repair. It's important in paresthesia cases to for infraocular nerve to get or also lingual nerve to get a post-op CT to make sure that we know the position of the bone. If there is a bone impinging on the canal, we want to definitely do a CT scan if there is paresthesia. And we want to see these cases on a routine follow-up. A lot of things that don't go well are cases that get lost in the follow-up. Usually, if you do a great follow-up with your patient, most of these cases can be managed. The other kind of final topic that I want to talk about is infection, prevention of infection after extractions. Use of antibiotics, it's very controversial. There has not been a good study that shows that antibiotic actually lowers rate of infection by much after extractions. There was one study that showed that it lowered the rate, but it's not to the point that was significant. So we want to really treat patients case by case, really want to go based on each individual patient, whether they have a certain medical condition, whether they're immune compromised, do they have uncontrolled diabetes, was the extraction very complicated, was there a lot of bone that was removed, and kind of choose case by case which cases we give antibiotic, which cases we don't. It's not really a kind of a general rule that every extraction needs antibiotic. No, it really doesn't. And, but there are cases that need antibiotic. So we have to really treat it kind of case by case. That's how I do it in my practice. I don't give antibiotic to every patient, but there are patients that I do give antibiotic to if I do suspect that they might develop a post-op infection. If you guys have any questions, these are my references. If you guys have any questions, you can email me or reach me on my site, and I'd be more than happy to answer.
Thank you so much, Doctor, for the wonderful presentation this evening, and thank you all for joining us tonight. We did record tonight's webinar, and we'll email the recording out sometime in the next week. We also would appreciate your feedback via our survey that will pop up on your screen shortly. Thank you all for joining us, and we look forward to seeing you on future webinars. Thanks again, Dr. Mahjoubi.